Greetings everyone, I'm Dr. Vijayashree, Assistant Professor in Department of Community Medicine. Um, Today the topic assigned for this hour is polio, and I will be talking about the epidemiological features, prevention of polio, in which I will be covering the vaccines, IPV and OPV, and I will be covering about the polio endgame strategy, and we'll be talking about the world picture or the global scenario and how it is in different countries, the current picture of polio, and also I will be giving you the pulse polio immunization, insight into pulse polio immunization, and I will be covering some important topics like switch uh, between the trivalent and bivalent and introduction of IPV into the schedule. All these things we will look in to this in this particular class. Now, coming to the introduction of this particular topic, polio is a viral infection, and the virus is an RNA virus. And this is a primary infection of alimentary tract, but it can infect our central nervous system in 1% of the cases, resulting in various degrees of paralysis, and it can be fatal also. Now let us look at the problem statement. Problem statement, by now I think you all know how is the picture of this particular disease globally and in various countries. Now it was found in all the countries all over the world in pre-eradication era. Then extensive use of polio vaccination since 1954 eliminated the disease in developed countries. The World Health Assembly resolved to eradicate polio globally in 1988. Since then, number of polio endemic countries have been brought down from 125 to 3 countries. In 2017, 3 countries were endemic to polio. Then you might want to remember these three countries: Afghanistan, Pakistan, and Nigeria, where the disease is endemic. And in India, this picture is that India is polio free since 27th of March 2014. And wild poliovirus 2 has not been detected since 1999, and it has been declared eradicated in September 2015. So there are three different types of wild polioviruses, 1, 2, and 3. Second one has been eradicated in 2015. And wild poliovirus 3 has not been detected since November 2012. So only wild poliovirus 1 is the only virus which is in circulation. And all this could be achieved by the extensive use of trivalent oral polio vaccine. And polio eradication and endgame strategy. This is the next topic, and it's very important. And how are we planning the endgame strategy? Attenuated poliovirus in oral polio vaccine can undergo genetic changes. This is a vaccine which is live attenuated, having live attenuated virus, and it can undergo genetic changes, resulting in vaccine-derived paralytic polio. So, indistinguishable, this vaccine-derived paralytic polio is indistinguishable from the wild poliovirus caused symptoms. And solution would be to stop all forms of OPV. OPV is oral polio vaccine, and IPV means um, it is injectable. And so oral, all different, the oral polio is trivalent, where all the three strains are there, bivalent, where two strains are there, 1 and 3. So all forms of OPV has to be stopped because we want to avoid the genetic changes, and we want to avoid happening of a single, even a single case of vaccine-derived paralytic polio. We do not want. So the ultimate solution is to stop all forms of OPV, and this needs to be done gradually. It can't be done just suddenly. It has to be done gradually. Thus, eradication and endgame strategy plan was started, and it was to be conducted from 2013 till 2018. Now, trivalent oral polio vaccine replaced by bivalent oral polio vaccine. Since I already told you, the second variety of serotype of poliovirus has been eradicated, so we don't need it in the vaccine now. So 1 and 3 serotypes are there in bivalent oral polio vaccine, and it was introduced. And also introduction of IPV, that is Salk variety of vaccine was also introduced. And steps that were involved were in 2015, by 2015, introduction of one dose of IPV into immunization schedule at least 6 months before the switching from trivalent OPV to bivalent OPV. And switch, I want you to remember this word, and it is a topic in polio. And switch will mean switching from trivalent OPV to bivalent OPV, and it happened in 2016. and plan for eventual withdrawal of all the OPV vaccines. This is the plan for the future. Now coming to switch, it happened in 2016, and bivalent OPV will have only viruses, contain type 1 and type 3, and it involves a switch. This program will involve global synchronized cessation of trivalent OPV, and it happened between 18th of April to 1st of March in 2016. And global synchronization of withdrawal of trivalent and introduction of bivalent OPV. At that same time, manufacturers were also not supplying the trivalent OPV. Manufacturing of trivalent OPV was also stopped. Now, switch from trivalent to bivalent is the key to eradicate the second serotype of the poliovirus. This particular switch program also serves as a dry run for withdrawal of other types of oral polio vaccines. We want to ultimately withdraw all different serotypes of oral polio vaccines. 1 and 3 are there right now in bivalent. That also we don't want to give to avoid vaccine-derived paralytic polio. Now that we withdrew the second type from the oral polio vaccine, this will serve, and we are observing what's going to happen, and that is a dry run and to check what happens when other two varieties are also withdrawn. I mean, when bivalent is also completely withdrawn. And then introduction of IPV protects against the type 2 poliovirus and boosts the immunity that is achieved from type 1 and 3. Then there's something called as containment, the virus containment. Wild polio virus 2 is not in human population, and it is not there in the environmental samples also. And it is there in the research facilities and also vaccination production sites. So because of that, there is always a danger of accidental spillage or malicious release. So this danger still exists. And there's something called as a fractional dose of IPV. There's something called as full dose, and the fractional dose of IPV is there. And this is given intradermally, and it is given at 6th and 14th week. It provides high seroconversion than single full dose intramuscular IPV at 14 weeks. Four objectives are there for the endgame strategy you might want to remember. We have to detect the virus, and you have to interrupt the transmission, and you have to interpretation. You have to detect the virus and interpretation of what different type of wild polio virus it is and its geographical origin and all of that. And then strengthening of routine immunization, which is already existing, and we have to do oral polio vaccine withdrawal, containment and of the virus, and certification also has to be done. And future legacy planning is what we will plan for the future, and whatever we have achieved, how to retain that particular achievements in polio case, a specific case, that is called as legacy. Now coming to polio surveillance, there's something called as surveillance. It is important to pinpoint how wild polio is circulating, and it is important to identify the new cases and importation of the wild polio virus. So for that, surveillance is important. Acute flaccid paralysis surveillance is there. So acute flaccid paralysis happens there is a differential diagnosis for acute flaccid paralysis clinical picture, not just polio, but other conditions like Guillain-Barré syndrome and transverse myelitis and traumatic neuritis. These are all the different conditions, differential diagnosis for acute flaccid paralysis. So acute flaccid paralysis surveillance will be happening, and whenever a case is detected with these symptoms, we check if it is because of polio or any other disease or syndrome. Now, what happens in this AFP surveillance is that finding and reporting cases with AFP sensitive enough to detect, we have to do this surveillance which is so sensitive that it should be able to detect one case for every 1 lakh children under 15 years, and transporting the stool sample for analysis. Two stool samples have to be collected in case there is an acute flaccid paralysis case. Two samples will be collected within 24 to 48 hours. 48 hours of onset. Symptoms will be there for within 48 hours. Two samples are collected, which are 24 to 48 hours apart. Um, And these samples are important to differentiate it from Guillain-Barré syndrome, transverse myelitis, and traumatic neuritis. We have to detect the virus in the stools. And then the third point in surveillance will be isolation of the polio virus. We have to isolate the polio virus and distinguish between the wild and the vaccine related virus. We have to understand if this particular acute flaccid paralysis is an adverse event following immunization, or it is because of the wild polio virus. If wild, you have to check if it is 1 or 3. Second one is again eradicated, so it is serotype 1 or 3, we have to check. Then we have to do something called as mapping of the virus. If the wild virus is detected, then its genetic makeup is found out to classify it with viruses from different geographical area. We have to find out from which geographical area has this come. Now, there's something called as environmental surveillance, where sewage and other environmental samples are checked for the virus. This kind of surveillance always confirms wild virus infection in absence of cases of paralysis. When there are absence of paralysis cases, it confirms if the uh, wild virus is present or not. And it provides supplementary surveillance data. Supplementary data it provides, and the surveillance indicators are also there. I will show you the surveillance indicators. You need not go into details and try to by heart all these. You might want for your theory exams or Viva at least. You might get some questions for your entrance examinations, but surveillance indicators, environmental surveillance indicators will be the completeness of reporting and sensitivity, how sensitive the surveillance is, and completeness of the case investigation. Each case that is detected, how completely is it investigated? Then completeness of the follow-up. How are you following it up? 60 days after the acute flaccid paralysis happens, you have to follow up the case for checking how weakness has improved and how it has progressed. And the laboratory performances also are surveillance indicators. Then there's something called as vaccine-derived paralytic polio. This term means it is an adverse event following the vaccination, and it is indistinguishable from wild polio virus. And incidence is 4 cases in every 10 lakh birth cohort per year in countries using oral polio virus. This event happens after the use of oral polio virus, not the IPV. Okay, and in the starting I already told you, we are that is why we are trying to remove or stop using all different types of OPVs. And vaccine associated paralytic polio occurs both in OPV recipients and their unimmunized contacts also. This is because the vaccine, the person who is vaccinated with OPV is excreting the virus in his stools, and thus his close contacts also will be receiving some amount of immunity, and the concept of herd immunity comes into play over here. That is why vaccine associated paralytic polio can happen in a person who's directly received the OPV or also in his unimmunized close contacts. And no vaccine derived associated paralytic polio is more because of sabin 3 than sabin 2 than sabin 1. And then you will understand this when I'm talking about what is SALC and SABIN, when I'm talking about prevention and the vaccination in polio. And polio virus isolates are characterized by global polio lab network, and they use RT-PCR for this. Now let us look into some basics of the polio, where we talk about agent, host, and environmental factors, and these are called as epidemiological determinants. First, coming to the agent factors, I have told you there are 3 serotypes, 1, 2, 3, and it survives, the virus survives long in external environment. In cold environment, it can live in the water for 4 months and feast for 6 months. So it has quite a long, survival time when the environment is favorable. And this virus is very well adapted to fecal-oral transmission and inactivated by pasteurization, physical and chemical agents. Then reservoir of infection is only man, and subclinical infection is also acting as reservoir for infection. Iceberg phenomenon is holding good for polio, where only tip of the iceberg is seen. For every one case, there are at least 1,000 subclinical cases in children and 75 cases in adults. So, and no chronic carrier is there, and the animal source is also not there. Then coming to agent factors, infectious material virus is found in the feces and the oropharyngeal secretions also. And Period of communicability is 7 to 10 days before and 7 to 10 days after the onset of symptoms. I will tell you what the symptoms are shortly. And virus is excreted for 2 to 3 weeks in some cases, and in some cases it can go to as long as 3 to 4 months. Now, coming to the host factors, everybody, all age groups are susceptible, but it is more in children. In children also, infants are more vulnerable. 50% of all the cases of polio are reported among infants and newborns and infants actually. And gender, it is 3 times, number of cases are 3 times more in males than females. And there are a few risk factors for polio: a person showing fatigue, a person who has sustained a trauma, intramuscular injections, and operations like tonsillectomy. These are some risk factors. Immunity, maternal immunity or maternal antibodies will protect the child for 6 months. Slowly they start disappearing, and cross immunity doesn't exist between the serotypes. And coming to the environmental factors, cold weathers and rainy season months will be between June to September. Then the transmission is most, and contaminated water, food, and flies, these help in the transmission, and overcrowding and poor sanitation aid in the occurrence of the disease. Mode of transmission, fecal-oral route we already know, and I want you to remember the droplet infection also. Don't commit and say droplet infection first. Fecal-oral route is the most important route of transmission for polio, and it can happen directly by contaminated fingers or indirectly by contaminated food, water, milk, and flies also. And the food, this is about fecal-oral transmission. Then droplet infection also happens because the virus is there in the oropharyngeal secretions, and this type of transmission is a risk for very close contacts of the cases. And incubation period for polio can be 1 week to 2 weeks. Now coming to the clinical spectrum. Now please pay attention. All cases of polio will not have a same clinical presentation. They will have a spectrum. It can be a mild form, abortive form, or it can be non-paralytic form, or a complete paralysis kind of a polio picture. So whenever a susceptible person is exposed to polio, one of these four responses can happen. First one is subclinical infection, inapparent infection, where the person doesn't show any symptoms, and it is recognized only by virus isolation or in raised antibodies. So there are no symptoms at all. Then second one is abortive polio, which is also called as mild illness, where the person will show mild self-limiting disease kind of a picture, and it is diagnosed clinically, and it is recognized, the condition is recognized by virus isolation and raised antibodies. Now, the third variety is non-paralytic polio. In this, there is stiffness of the neck and back, and the person will have these symptoms for 2 to 10 days. And in this condition, recovery is rapid. And the last variety, and which is the most serious form of the polio, is happening in less than 1% of the cases, and it is called as a polio or paralytic kind of polio. In paralytic kind of polio, what happens is CNS is affected. So what I'm trying to explain to you is, whenever a person, susceptible person, is exposed to RNA virus, polio virus, four different pictures can happen. And the last variety, most severe and dangerous form of polio, is paralytic polio, which happens in less than 1% of the cases. So, and the CNS is affected, the central nervous system is affected in them, and degrees of paralysis will vary. It is different in different cases. Asymmetrical flaccid paralysis will be there in them, and fever at the time of onset of the paralysis will be there, which should hint that it is having a polio kind of a picture. And acute flaccid paralysis will be there. Then you check for the virus, presence of the virus. And the person will have malaise, anorexia, nausea, vomiting, headache, sore throat will be there, constipation, abdominal pain. These are some other symptoms. Meningeal irritation signs like stiffness of the neck and back will be there. And then there's something called a tripod sign. I want you to pay attention to this particular sign. You can, I could not put a picture of tripod sign, but you can quickly Google. You will remember it once you see it. What happens in this is the child finds it difficulty in sitting, and what the child does is he squats with his hip and knees flexed, and he squats, and he will not be able to sit in that position. It is difficult for him to sit. So what he does is he puts his hands at the back of the hip and he takes support and then he sits. That is called as tripod sign. And there is something called as descending paralysis, where the paralysis will start at the hip and it moves down to the distal extremities. And then there's something called as asymmetrical patchy paralysis, in which the muscle strength varies in different muscle groups, various muscle groups. The muscle strength is different in different muscle groups. That is why it's called asymmetrical patchy paralysis. Proximal muscles are involved more involved than the distal, and the deep tendon reflexes become diminished at the onset of before the onset of the paralysis, and there is no sensory loss in these patients, and cranial nerves are also involved if it is bulbar or bulbospinal form of polio, and facial asymmetry will be there in some patients, difficulty in swallowing will be there in some patients, and loss of voice will be there in few patients, and respiratory insufficiency happens if respiratory muscles are involved, and it can be fatal. And after the phase passes, acute phase subsides, what happens is there is atrophy of the affected muscle groups, and it is resulting in residual paralysis, with which the person has to learn to live, do physiotherapy, and then try to regain the muscle strength as much as possible, but there's some amount of residual paralysis which persists. Now the topic which is next is treatment of polio. There is no specific treatment. And good nursing care has to be given right from the beginning, and also physiotherapy has to be started at the earliest, and to regain as much muscle capacity and strength as possible. And these two will, minimize the amount of a degree of crippling. And metal calipers are available for limbs. And the topic next is prevention. In this, immunization is the only effective measure for preventing polio, and we have both killed as well as live attenuated vaccines available, and two types of vaccines, IPV and OPV, like you already know. Now let us look at SALC or IPV, and OPV will be Sabin. Now IPV, we will finish off the details of this particular vaccine first. It contains 40 units of type 1, 8 units of type 2, and 32 units of type 3D antigens, and it contains traces of formaldehyde, streptomycin, neomycin, polymyxin, and ethanol. And thimerosal is not used in IPV as it is not compatible, and adjuvants are not there in IPV. Components are important because sometimes some entrance exam questions will be there about all these components, adjuvants, and all those things. And people who are allergic to streptomycin, you should bear all those things in mind while administering this particular vaccine, because the vaccine has streptomycin, neomycin in it. So we have to be careful. We have to be wary of the fact that it has streptomycin, neomycin, formaldehyde. So people are allergic to these components. So when we know what other things are there in the vaccine apart from the viral components, we will be knowing in whom it is contraindicated. So that is why we have to study which vaccine has what type of adjuvants and what type of other components, stabilizing agents. So this is administered by intramuscular route. IPV is given intramuscular route, but there's something called as fractional dose of IPV, which is given intradermally, and this has to be refrigerated, and you should avoid freezing the IPV, and it can be given as standalone IPV or combined with DPT, and combined with Hib and Haemophilus influenza, and it contains the combination. See, this particular combined vaccine will have pertussis component and also alum. These two will have adjuvant effect on the polio vaccine. And 4 inoculations are recommended for IPV. First, second, and third doses are given at intervals of 1 to 2 months, and fourth dose is given at the interval of 6 to 12 months after third dose. First dose should be started at 6 weeks. Okay, and that means 6, 10, 14, and after 14 weeks, 6 to 12 months gap is given for third dose. And additional doses are recommended before the child goes to school, and also from there on every 5 years till 18 years. OPV can be given after the initial inoculation is completed with IPV. OPV can be used simultaneously with IPV. And IPV will induce humoral antibodies, IgM, GA, and it doesn't include intestinal and local immunity or antibodies. This is a difference between IPV and OPV, so you can pay attention to this particular point. The immunity which is happening because of IPV is not rapidly achieved, and it is not recommended during the epidemic time. So these are the 3 points which are different from the OPV and IPV. Now, what are the advantages of IPV? Is that it doesn't contain live virus and it is an inactivated vaccine, unlike OPV, which is attenuated virus, live attenuated virus. So this IPV can be safely used for immunodeficient diseases, people who are elderly, who are getting vaccinated for the first time, and safe in pregnancy, and it doesn't have serious adverse effects. And now the next type of virus, which is Savin oral polio vaccine. Sorry, and it is having all three types of viruses, serotypes 1, 2, 3, and it is grown in primary monkey kidney or human diploid cell culture. And the contents, it is difficult to remember, but for entrance examination purpose, you might want to memorize. And I was not able to put the superscript and subscript in this. If you check in the text that is there in your book, you will understand that there are some subscripts and superscripts in this particular contents. And national immunization schedule is uh, existing in India, and EPI is by WHO, and it is recommending both these things are recommending 3 doses of OPV at 1 month intervals, and first dose which is starting as 6 weeks. Zero dose is also given, and zero dose is given to children who are born in health facilities before discharge. And combined vaccine is given along with DBT, and it's called pentavalent, and zero dose along with BCG, it can be given safely. BCG is given birth dose or zero dose along with BCG can be given. And complete vaccination. Vaccination has to be completed by 6 months, as maternal immunity will start decrease after that. And most cases will occur between the age of 6 months to 3 years. So that's why we have to finish the vaccination with OPV before 6 months of age. Then dose of administration, dose and mode of administration, 2 drops you have to give OPV, and tilt the child back, gently squeeze the cheeks or pinch the nose to make the child to open the mouth. And you have to put the drops directly on the tongue and check that the child has to swallow them. If the child is spitting, you have to repeat. And development of immunity, first what happens is the live vaccine, the strain infects the intestinal epithelial cells, then the virus is transported to Peyer's patches where secondary multiplication will take place, and the virus will then spread to other body parts, resulting in circulatory antibodies, which prevent the dissemination of the virus to the central nervous system, and it is preventing the paralytic polio. Intestinal infection stimulates the production of IgA, and which is in turn limiting the community transmission. It is limiting community transmission. And OPV induces both local and systemic immunity. It is giving both the immunities. And herd immunity is the next topic. I already mentioned about this briefly. Um, this virus is excreted in the feces, and secondary spread also happens. Um, and it's excreted in the feces for the vaccinated individuals, I mean to say, and it's spreading, secondary spread happens, and it is occurring to the household contacts and susceptible contacts in the community. By this process, unimmunized people may also be, immunized indirectly, and herd immunity is achieved when 66% of the community is immunized. It This property of OPV has been exploited in controlling epidemics of polio by administering vaccine simultaneously in a short period to all susceptible people in the community. This procedure eliminates the wild polio virus in the community, and replaces them by attenuated strains of viruses. And duration of immunity produced because of OPV is not known, and it could be lifelong protection also. Advantages will be that this OPV can be given orally, and there is no need of training the staff. And both humoral as well as intestinal immunity is attained. Antibody produced in large proportions, and single dose is enough to have a sustainable immunity. We have 3 doses and beyond, but single dose also will give sustainable immunity. And vaccine, the air virus is excreted and it infects others, leading to immunization of the others also. It is useful in controlling the epidemics, unlike IPV. This is a different point, differential point between IPV and OPV, and it is inexpensive. OPV is inexpensive. Now, coming to the complications of OPV, it is free from complications. but vaccine-associated paralytic polio can happen, and mutations will be there in the live attenuated virus in the vaccine. So VAPP can happen. It occurs both in oral polio vaccine recipients and the unimmunized contacts also. Now, OPV is contraindicated. We have to check the contraindications for this particular OPV. Diarrhea is not a contraindication. Um, is not a contraindication, but if the child gets diarrhea, if the child with diarrhea got OPV, it should not be counted that the child should not get another dose at first available opportunity. So what we do is we get another dose at the next immediate opportunity. You have to take another dose of OPV. That particular dose we will not count. Live vaccine are contraindicated in immunocompromised patients and contraindicated malignancy, leukemias, and corticosteroid therapy patients. And IPV should be given in place of OPV in HIV positive infection patients. It is safe in pregnancy, and it is safe for the mother as well as in the fetus. Storage, it is heat stabilized. The vaccines are heat stabilized by adding magnesium chloride to them, and it can be kept at 4 degrees for 1 year, at 25 degrees for 1 month. And if the vaccine is OPV is not heat stabilized, then it has to be stored at minus 20 degrees in a deep freezer. So you have to know what is stabilized OPV and not stabilized OPV. It is stabilized for heat, heat stabilized if magnesium chloride is added, and otherwise if it is not heat stabilized, minus 20 degrees deep freezer you have to put. During transportation also it must be kept on dry ice, and it has to be put on a freezing mixture. Now what is dry ice, what is freezing mixture is given on this slide. You have to know this. Now vaccination clinics, vial should not be frozen and thawed repeatedly. In vaccination clinics, you should not freeze and thaw, because it will lose its vaccine potency, and it should be kept on the ice packs. And breastfeeding doesn't impede the efficiency of OPV vaccine. Breast milk can be given to the child whenever the child is hungry, but hot water, hot milk, and hot fluids should be withheld after OPV is given for at least half an hour. And problem with OPV is that it is unstable at high ambient temperatures, and it should be kept frozen during the storage, cold during transportation, and the whole cold chain has to be maintained. And during administration also you have to be very careful. And frequent vaccination failures even have been observed even after full potent vaccination have been administered. And vaccine leads to a very small residual neurovirulence. Now, sequential administration of OPV and IPV, combined schedule of IPV OPV appears to reduce or prevent the vaccine-associated paralytic polio while maintaining the high level of intestinal mucosal immunity, and which is conferred by OPV. Combination leads to humoral mucosal immunity, immunogenicity of the polio vaccination. We need both humoral as well as mucosal immunity. So this combination of IPV OPV is achieving that, and effectiveness of this approach is preventing polio caused because wild polio virus as well as vaccine associated paralytic polio. Now these are some differences which we all already discussed. Quickly we'll go through the differences between IPV OPV. Killed formaldehyde killed form of vaccine, and OPV is live form, and it is given intramuscularly IPV, and OPV is given orally. And the type of immunity induces circulatory antibodies but not local immunity. OPV is both humoral as well as intestinal immunity. And IPV prevents paralysis but does not prevent reinfection by wild poliovirus. OPV prevents paralysis as well as intestinal reinfection. Mm, it is IPV is not used for controlling epidemics. OPV can be used, and IPV is difficult to manufacture and it is costlier, and OPV is cheaper and easy to manufacture, and IPV does not require stringent conditions for storage and transportation, while OPV, which is very heat sensitive, needs complete cold chain maintenance. Now, there's something called as epidemic investigation. Whenever there is acute flaccid paralysis happens, we have to do a complete epidemiological investigation. The name of the administrative area and location has to be noted. For a date has to be noted where the first case was identified. The period of the field investigation has to be noted from and to date, and number of paralysis cases detected, clinical diagnosis, laboratory confirmation, as well as type of virus isolated should be noted. Number of deaths because of paralytic polio have to be noted. Number of paralytic cases in each different age group have to be noted. Number of contacts of paralytic polio have to be noted. Household contacts, and brief description of the investigation field has to be noted. Field how it is, and you have to describe how it is. History of previous investigation practiced in this particular locality, and when was the last vaccination program carried out. All those things should be noted, and name of the principal investigator has to be noted along with the laboratory. Now, these are the strategies for polio eradication in India, and in this, what they have done is pulse polio immunization was done. These days were done every year until polio was eradicated, and these are to be conducted, and sustain high level protein immunization coverage, and monitor OPV coverage at district level and below, and improve surveillance capable to detect all the cases. AFP due to polio and non-polio etiology have to be investigated. Like I said, all the 10 epidemiological investigation steps have to be followed. Ensure rapid case investigation, including the collection of stool sample and virus isolation. Arrange follow-up of the acute flaccid paralysis case at 60 days, and you have to check for the amount of residual paralysis, and conduct outbreak control for cases confirmed or suspected to be poliomyelitis to stop the transmission. Then there's something called as line listing of the cases. In this, what we have to do is the medical officer of the district is responsible for this. In this, name, age, gender of the patient is noted, the father's name, the complete address, vaccination status, date of onset of the paralysis, date of reporting, clinical diagnosis, doctor's name, address, and phone number are noted. This is line listing of each and every case. Now, there's something called as mop-up round, which is for vaccination. Mop-up activities are usually last stage in polio eradication. We are doing very good routine immunization program in India, but mop-up rounds are to catch hold of people who were missed in routine immunization and give vaccination to them also. In this, what we do is the strategy is to do door-to-door immunization in high-risk districts where wild polio virus is known to exist, and this strategy is being implemented in India. Pulse polio immunization, we must have heard about this, and you must have participated also in pulse polio drives. It is a national level drive and the largest public health campaign ever conducted in a single country. And the pulse polio campaign started in 1995. Two immunization days are there, 6 weeks apart. And target was initially less than 3 years children. Now it is extended to 5 years, and it is done between November and February. So these details are important, you have to know. And all states and union territories should develop rapid response teams for to respond to any polio outbreak. And rapid response teams are in place, and they will become active whenever there's an outbreak. Emergency preparedness should be there, and response planning developed for the detection of polio cases. All these things are there, and they are functional as a part of polio program. And in UP Bihar, every newborn child identified, vaccinated, and tracked for 8 subsequent rounds. And in order to reach every child, vaccination is also provided at railway stations, trains, marketplaces, and religious congregations. High level vigilance through surveillance for vaccine derived paralytic polio. Environment surveillance also has to be done, and multi-pronged strategy has to be done, not just vaccination and acute flaccid paralysis surveillance, but we have to improve sanitation, hygiene, clean drinking water. In addition to vaccination, we have to do all these, and migratory children from UP, Bihar, they also have to be covered by sub-national immunization days. And social mobilization has to be done, where local leaders, community leaders, and religious leaders, those people are also helping us to mobilize the people and to break the stereotype where many people don't accept polio drops for whatever reasons. So we take the help of these community leaders and religious leaders to educate them and to break the stigma. Um, a rolling emergency stock of OPV is being maintained in case there is a sudden outbreak.